Now, exactly, which patients may benefit from CART therapy. So, patients with germline and somatic BRCA mutations, but also those with hypermethylated and perhaps even those with the BRCA profile may also benefit from chemotherapy, PARP inhibitors, if we can identify them. Now I wanted to sort of move on to recent advances in cervical cancer, and I'll have to hurry up through this part. So as was mentioned earlier, so I don't want to dwell on this study too much, GOG 240 was actually published in the last year in the New England Journal of Medicine, and I think it really is a practice-changing study. So this is a study in patients with metastatic recurrent or persistent disease. They were randomized to cisplatin paclitaxel with or without bevacizumab and topotecan paclitaxel with or without bevacizumab, so a 4-arm randomized study. And they showed that there was an improvement in progression-free survival with the cisplatin paclitaxel compared to topotecan paclitaxel, but no difference in overall survival. Now, if we look specifically at chemotherapy plus or minus bevacizumab, we see that there was an improvement not just in progression-free survival, but also in overall survival. And these results resulted in the FDA approving bevacizumab in combination with chemotherapy for recurrent or metastatic cervical cancer. I should note that there were a number of fistulas, and these fistulas were confined to the chemotherapy and bevacizumab arms, and all occurred in patients with prior radiation. So we have to be very careful, not that we wouldn't necessarily give bevacizumab to those patients, but we have to let them know that this is a potential complication of this therapy. Now I want to move on to just advances in radiation for cervical cancer. So historically, the way we've prescribed brachytherapy for cervical cancer has been with use of the Manchester system, which prescribes dose to point A. And for those of you who don't know, point A is a prescription point that's really based on the applicator geometry. It's 2 centimeters above the ovoids here and 2 centimeters lateral to the uterus. So it's really irrespective of a patient's tumor geometry, how big the tumor is, what the stage is, if they've had any tumor regression at all. And so what you end up with is this nice little pear-shaped isodose distribution, and I'm pretty sure most cancers don't look quite like a pear. And so you can see here what are the consequences of this. Well, the tumor is contoured here in red, and in the cyan, the blue color here, is the 100% isodose line. So you can see here in this A panel that the brachytherapy treatment, the prescription to point A, does adequately treat the tumor, but perhaps more than adequate. It's also the isodose line is going into the bladder here, so you're probably getting some excessive normal tissue toxicity. Now in the panel B, you can see the cyan line is the 100% isodose line covering the tumor, although the tumor extends just a little bit outside the tumor, and so maybe we could have expanded this a little bit to better cover the tumor.